Well, welcome everyone to the UBC Learning Circle, hosted by the Center for Excellence in Indigenous Health. First, I'd like to acknowledge the unceded ancestral lands of the Musqueam people, where we're hosting this session from today. Also like to acknowledge the First Nations Health Authority for generously funding the Learning Circle. We also have staff here today from the First Nations Health Authority. And today's session is taking care of each other, Indigenous perspectives on harm reduction. Very important topic for our communities, looking at the overdose crisis, which is impacting our people every day. People are dying, and all of us have, people in our lives that are impacted by addiction. So I'll introduce myself. My name's Melanie Rivers. I'm from the Squamish Nation. My Statlium name is Mlamawit, which means medicine. And I'm the New Education Coordinator for the UBC Learning Circle. I've got folks in the room here that are helping out with the sound and technology, Davina and Javier. I'll turn it over and welcome our guests in a moment, but I'll just go over how the session will go today. So the Indigenous Wellness Team have a PowerPoint presentation, so they'll go through that and they've also got a video. So at the end of that, we'll have a question and discussion period. So that's where you can pop your comments and questions into the chat box. Feel free to make comments as we go along as well. Just ensure that you select all attendees so that your comments go out to everyone. And please introduce yourselves in the chat box. So really pleased today to invite the Indigenous Wellness Team from the First Nations Health Authority. A topic near and dear to my own heart. I worked in HIV/AIDS for many years and seen this impact of addiction and the overdose crisis on our communities. So I'll turn it over to our guests to introduce themselves and share their PowerPoint.
Good morning, everybody. My name is Andrea Medeiros. My Haida name is Gidikoyas. I'm from Old Masset, Haida Gwaii, and I'm the educator on the Indigenous Wellness Team. Really happy to be here today.
Hi, everyone. I'm Sherilyn Cortez. I'm a nurse with the Indigenous Wellness Team. I'm not Indigenous. I'm a Filipino person. My parents actually immigrated to Winnipeg, which is actually the traditional territory of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene people, and it's the homeland of the Métis Nation. And I'm very happy to be here with my most favorite team I have ever worked with in my life, and that will always be true. And you can't see, their off-screen is Andrea Durbin and Janine Stevenson, who is the best manager I've ever had in my life. So there. Thank you, very happy to be here.
Good morning, everyone. My name is Len Pierre, and I am Coast Salish from KT First Nation. I've been with First Nations Health Authority for 2 years now, and I am the Indigenous Wellness Cultural Designer with our Indigenous Wellness Team, and very happy to be here. Haichka. So with that, our hands go up to each and every one of you for joining us and spending your important time to, embark on a conversation that is very near and dear to very many of us and very many of our communities, as we've learned over the last 2 years as being a new team at First Nations Health Authority. It's been a very busy year since the last time we've been at the UBC Learning Circle. So what we are here to share with you today, a little bit of an overview, is we're going to give a slight update on the public health emergency, as well as some new developments within our dialogue around decolonizing addiction, which is really about coming to a collective understanding on what addiction and substance use means for us as communities, and then we'll get into Indigenous harm reduction.
We should have about 15 minutes at the end for Q&A.
So a little bit of background and about the work that we do. Everything that we do, we take community is our leading star in all of the work that we do. Everything that we do is by permission and in partnership and walking with all the communities that have invited us to sit at tables and have very, very important conversations about addiction and substance use. So everything we do is led by community conversation, and everything that we share is by express permission by our communities that we've engaged with. Everything that we do also is looking at beyond the crisis and really taking a look at transformation, and that's a little bit twofold. The first is to say is that we are harm reductionists, and that when we walk into communities, we talk about the opioid overdose crisis. But when we're in community, we take this humble approach that when we're visiting and we're sitting at those tables, we're speaking about potentially one crisis that could be apparent in the community. We have many communities that are talking about mental health. Many communities that are talking about food security and home security. So we recognize that when we walk in with an agenda item, that it might be one agenda item of many agenda items for many of our communities. And the second part to that is to really honor and recognize the resiliency that each and every one of our communities have, that we've endured many crises since time immemorial. All of our communities have stories about the Great Flood, stories about first contact and surviving the smallpox epidemic, surviving residential schools. And so when we look at this crisis, we want to say that 100 years from now, when we look back, how do we want to say that we responded as our communities, recognizing and honoring that resilience. And then, of course, working together is at the heart of everything that we do. And our hands go up to all of our communities, but not just our communities, but our partners across the entire province. And that's our harm reduction coordinators. Those are our sister programs in Indigenous sexual health and in Indigenous harm reduction. So haichigat to each and every one of you.
And the picture on the bottom there is an example of us working together. That's Kayla Mitchell, the program manager at Yostuwas, the Indigenous Health Program under Youth Co. And I think also we've done, it's important to mention the number of workshops that we've done. We've been really busy, as Len mentioned. We've done over 70 workshops since last April. We've been busy on the road, and I'm sure we've worked with many of you that are tuning in today. We also have well over half of First Nations communities distributing naloxone, which is really amazing.
So many of you know this, but we are coming up to 2 years since the provincial public health emergency was declared in April of 2016. And unfortunately, when it comes to the number of people that have died, things have not improved. So last year, we actually had the record number of deaths. 1,436 people died in 2017. In 2016, 995 people died, and it was 518 people that died the year before that. It's important also to say that these deaths are unintentional overdoses. We have the provincial health officer, we have leadership across all of the health authorities that have come out publicly to say that these are accidental poisonings. And actually, these accidental poisonings have been happening to over 200 people every year for the past 25 years. And for the most part, our society remains silent about these deaths. Another thing to mention is that even the term opioid crisis or opioid public health emergency can kind of lay the blame and the focus too much on a particular substance, when we know that this is more than just fentanyl that's at the cause. Actually, and I call Andrea Meds, we all call her Meds. Meds reminded me the other day that it's not just about a substance, it's actually the system of oppression and racism that has led to the epidemic that we're in now. So actually, it's those systemic factors that are talked about in great detail in this report. For those of you that haven't seen it, please Google it. It was released last July, and it's the preliminary findings on the overdose data in First Nations in BC. One thing that's really important, that if you turn to the first page, it begins with the statement, good health interrupted. And I think it's really important. One thing that I learned actually from Chimamuk, which is an Indigenous organization that works around HIV and Hep C, they would always say, like, when you're talking about a statistic, there's always a person behind that number. There's always a story behind the data. And so what's really good for people who are not Indigenous, like myself, is that this report talks about the story behind the data first, before just presenting the numbers. It goes on to say that First Nations people enjoyed like a rich history and have for thousands of years of wellness and health, but that colonization did introduce devastating impacts. And some of those impacts are presented now in these numbers that we have. So, for instance, 3.4% of the population in BC is comprised of First Nations people, yet 14% of all of the overdose deaths involve First Nations people, and 10% of all the deaths involve First Nations people. So First Nations people are 5 times more likely than non-First Nations to experience an overdose event, and 3 times more likely than non-First Nations to die from an overdose. Another unfortunate thing about data is that it's often presented binary. So here we're just looking at just 2 of the genders, male and female, but you can see that the distribution is different for First Nations people than in the general population. So in the general population, it's more men that are affected by overdose events, but in First Nations populations, it's more evenly split. It's 52% men to 48% women. So what's really important about what's happening is that the First Nations Health Authority has actually created a plan of action. So this is kind of the response to the epidemic that we're in, and it involves 4 key action areas, and inside each of those action areas are specific goals and plans. And another thing to note is that this isn't just being done by the First Nations Health Authority alone. The epidemic that we're in is actually a shared responsibility, and it's shared across all health authorities. This is a problem that we all need to solve together, not just First Nations people. And so, for instance, our team, we work with our partner organizations, we work with our harm reduction coordinators to support actually the leadership that has come from community around this crisis. So, for example, the first action area is prevent people who overdose from dying. And as Meds mentioned, over half of the communities in BC have been trained in take-home naloxone, and they were actually some of the first groups that asked for and demanded for take-home naloxone training when the emergency was first declared. So secondly, there's keep people safe when using substances. Some people might look at that and say, okay, we have overdose prevention sites, that's great, we have safe injection sites, but what it means actually from the First Nations Health Authority perspective is to really engage peers in a really meaningful way. So one thing that's going to start unfolding is that we're going to start supporting peer coordinators, and so these are people that have lived experience with substance use, people that live in communities, and they really have an expertise and a knowledge that really can't be found anywhere else. And they're really going to be key in shifting the stigma and the discrimination that people who are engaged in substance use experience. So there's really a power in peers, and that's something that in the second action item is really going to be held up. Thirdly, there's create an accessible range of treatment options, and so certainly that does mean supporting communities and their physicians and their nurses around things like opioid agonist therapies. But Meds and Len always remind me that in the medical field we have such a limited view of what treatment means. We often think of it as a drug or a medication, but in First Nations health, what I've learned from these folks is that treatment goes beyond that. There's land-based treatment. Treatment is culture, and that's something that we learned from a lot of our partner Indigenous organizations. USNUWAS has these nights that they hold regularly called Culture's Healing, and then there's Culture Saves Lives, Patrick Smith's organization. So it's something that we can learn in the medical community from First Nations people, that treatment isn't this limited view. And then finally, we support people on their healing journeys as an organization. And so, for instance, we just recently announced that we're supporting communities. We're supporting some of the leadership and the initiative that communities have taken on, and we're supporting them through harm reduction grants. So I think it's, we're kind of in this time, it's really, there's been a lot of loss, there's been a lot of devastation, but I think there's a lot that we can learn from First Nations people about how we're going to come through this epidemic. And for those of you that are out there that are wondering, what can I do? If you're Indigenous or if you're not Indigenous, one thing that you can do actually, in addition to, speaking out against stigma, in addition to supporting the people in your lives that are engaged in substance use, one thing you can do is start questioning the way we've been doing things. And what I mean by that is start questioning this system where we keep all of these substances illegal. So Meds and I were at a conference recently, and so they were talking at this conference about the impending legalization of marijuana. And they were saying, they were talking about what's a safe dose? Once this becomes more regulated and legal, what's a safe dose? How old should a young person be before they can start buying it in the stores? And so Meds and I got up and we spoke and we said, this is a really great conversation that we're having. Perhaps if we had this conversation about all these substances that are currently illegal, we wouldn't have so many people dying. Because honestly, if we continue to keep these substances in the illegal sphere of our society, then we let those people decide what is safe. We let those people decide what the dosage is and how much goes into what we're taking. Janine Stevenson, our manager, she gives us really good talk about prohibition, and she often says prohibition equals potency, and she's absolutely right about that. We are now in a situation where prohibition has created this illegal, super strong, super portable version of a drug that is normally regulated and is normally safe, fentanyl. So prohibition equals potency. Prohibition also equals powerlessness. So if we continue to keep these drugs in the illegal sphere, we as public health professionals, as loved ones, as parents, as sisters, we don't get a say at all on how to keep these substances safe. So that's my little soapbox for now. One lighter story that we'll end on. Meds and I were at a talk, and Meds was giving this really good talk, and she was really doing a good job about talking about the benefits of decriminalization. And we were so shocked often, and Len also were often shocked sometimes at where people are at when we're visiting communities. And this one elder stood up and said, so how can we be more like Portugal? How can we do this? Who do I write to? Who do I talk to? And Meds was like, I just want to hug you right now. And he was like, I wait. So, yeah.
You guys want to explain what Portugal's doing?
Oh yes, Portugal has essentially decriminalized the substances, and so basically, instead of pouring all this money into enforcement and policing and criminalization in jails, they put that money instead into support, into destigmatization, into treatment, and so they're just not seeing the problems that we're experiencing now with substance use, and they're certainly not experiencing the number of deaths that we've been experiencing, not just in this province. This is happening all across the country. It's happening in the States and in other parts of the world. So.
So now we're kind of getting into our segment around decolonizing addiction, which was completely created out of community conversation, and it's something that we're going to kind of bring up throughout all of our conversation today and time today, is about just honoring and recognizing that everything that we are presenting today is based out of a community invitation to come and talk. And really that's what we try to do is emphasize how important a conversation is around what we can do to change the way we've been doing things. And when we have the humble honor, and it really is a humble honor to be invited to communities and for communities to share with us work that they have been doing for a long time. We've been in the north where communities have made a community hall available for a weekend dance so that people can be together and party. And then we've had people, communities in the north that have gone around and driven around at night to make sure that nobody's left out in the cold on a weekend. On the island, we've had leadership have conversations with us about investing in homes for people who are using substances or people who don't have a home so that they have a safe place and access to care and services. We've had conversations in Fraser where elders have supported their youth, the entire youth in their community be trained in take-home naloxone. And the stories just continue. And it's great that we have such that humble honor to share those teachings and share those stories of care and compassion and kindness across the province with service providers and with partners. When we get into decolonizing addiction, it really is about decolonizing our thoughts and our mindsets, our patterns of behavior on how our attitudes about addiction and our actions around addiction over the last 100 years, let's say. So a good place to start is to take a moment and just think for yourself is, how would you define addiction? What words come to mind? What images come to mind? And that's where we start the conversation first.
I think when our team came together 2 years ago at the beginning of the crisis, we were often asked, initially we were asked to do take-home naloxone. And we were doing take-home naloxone training, and sometimes we'd get calls to come back or emails saying, we did naloxone training, but people aren't coming to the health center to get the kits, or we're having trouble getting the training out there and making sure the people that are using substances or the people that are in relationship with people who are using substances have the naloxone training. And so we, based on the kind of conversations we were having, realized we had to take that time to talk about our definitions of addiction, because I'm sure every person that's tuning in today has a different definition about what addiction is, because it's all personal and it's complicated and it's sensitive and it's touched all of our lives in such different ways. And so we found that it was really important to start the conversation in a way that we had come to this shared understanding. So then once we are on the same page about what we think addiction is, then we can talk about harm reduction. Then we can better implement the take-home naloxone training that is so important and such an important response in the crisis right now. So we did touch on this a bit in our last year's version of this presentation, but I think it's important to revisit because like I said, there are so many different definitions of addiction, and we've had all these different interactions which give us definitions, and we're told different things by the profession. So Sherman mentioned the medical kind of perspective is, well, we wouldn't probably call it addiction, and in medical terminology we'd say substance use disorder, something like that. And often if it's a medical condition, then we'll prescribe a medical treatment, and that's certainly part of it, but it's not the whole story. If we look at the criminal kind of definition, we'll say, well, drugs are illegal, so if you're gonna use drugs, then you're just gonna go to jail, right? And that's kind of been our response for the last 200 years. But that's really not working for people. Just going to jail, that doesn't solve the problems. And if you look at a place like the United States, where they have 5% of the world's population, they have 25% of the world's incarcerated people. 1/5 of the people are in jail because of drug-related crimes, many of them personal possession. So is that really working? Questionable. We have this social definition, which looks at more broad pieces, the social determinants of health, like how much education people have, and poverty, and housing, and these sorts of determinants and pieces that make up people's lives. And I think that's hitting the nail closer, like it's getting us to better definition of looking at these systems of oppression that we talked about. And then we have the individual definition, which is closely tied into the criminal definition, is that, drug use is a choice, and if you made that choice, then we often leave people to deal individually with these consequences. And what that does is that puts all the focus on the person and on the substance. It doesn't allow us to look at the greater issues like lack of housing and poverty and the things that contribute to addiction. And then we often say, what is the cultural definition of addiction? Which we will be getting into.
As Andrea was saying, it was really important before we even put take-home naloxone on the table for a conversation. It was really about making some safe space and safe place to talk about addiction and talk about substance use. Who is using substances and where are people using substances? And this brings up a whole bunch of different emotions because addiction and substance use is very personal. And when we put addiction on the table for conversations, our minds start going to people who are loved ones who are using substances, people in our communities who are using substances, and of course we'll probably reflect on one of those many definitions that we talked about in the previous slide. So we always want to come to a place of starting with why. Why decolonize addiction? Really, it's about creating a collective understanding about sensitive and complex topics in close-knit communities. Because in our communities, everybody's related to everybody, everybody knows everybody, so they're very close-knit. And so for something as sensitive and complex as addiction, it's really, we need everybody on the same page and facing the same direction and the same approach. To make clear linkages between colonialism, trauma, and addiction and substance use. Most importantly, it was about removing the blame from people who might have experienced trauma. And then, of course, to respectfully balance the tone of the conversations and move forward in a good way. Invitation for mindfulness between abstinence-based and harm reduction messaging. This is a concept map that we have developed to help guide two things. To map out where our attitudes about addiction come from and how those attitudes might affect our actions when we're talking about addiction and substance use in our communities. So we take colonization as one of the root causes of addiction, and then we highlight 3 colonial events. There are many colonial events that we have endured here on Turtle Island, but for this example we've chosen 3. The residential schools, the 60s scoop, and land theft. And if you notice above the colonial events, there are 3 or 4 what we call residues, certain aspects that we unintentionally and uninherently pass on to the next generation. So for example, above residential schools there you see a sense of fear and shame, especially towards institution or a sense of authority, a sense of isolation, and a sense of learned helplessness. And for the 60s scoop, not everybody is quite as familiar with the 60s scoop as residential schools, but the 60s scoop is during the 1960s where generations of children were removed from their families and their communities and placed into a foster care system as another assimilation policy by Canada. And so residues left behind from that colonial event could be a sense of detachment, definitely a loss of identity, and definitely a loss of rights. And for land theft, poverty, lack of housing, and a loss of freedom. And for each of those residues, there are drivers and reinforcers for what we label trauma, grief, loss, and a sense of daily stress. And those are drivers and reinforcers for addiction. And you notice on beside addiction there, I don't know if everybody can see it, but what we like to do is broaden what addiction can look like, because quite often when we put addiction on the table for conversations, our mind goes first to substance use, and then maybe alcohol is a really close second. But then we brainstorm with our communities is, well, what are those socially acceptable forms of addiction, or those hidden forms of addiction that we might not see? And that's where we get into our conversations about work and how work can be addicting, shopping and consumerism, sex, gambling, food, caffeine, and our phone and technology. So just broadening our understanding of addiction, that addiction takes many forms and some are more socially acceptable than others, but they're all used, to kind of cope with or interrelate with trauma, grief, loss, and daily stress. So for mapping out where our attitudes about addiction come from, we have 203 communities here in BC, all with our own different distinct cultural practices, traditions, languages, and dialects, and independence. But we're all united by a common story, and that story is the residential school's legacy. And every single one of our communities, we have this very high value on abstinence-based messaging and abstinence-based programming. And that's has been in the past a part of the pattern and just a recycled value that we have is just say no, don't do it. Just say no, don't do it. And why is that in every single one of our communities? Well, if we come down the left side of the map there, we're going to land on residential schools. And who ran the residential schools? Religious churches. And religion is all about abstinence. Just say no, don't do it. So it's a colonial event that has happened, and it's a colonial event and practice that we exercise and recycle in our own communities. And a story that we had a couple weeks ago when we were in the north, a young lady who's doing great work in her community says, yeah, when we're recycling that, what we're doing is we're really just colonizing ourselves over and over again. If we're taking colonial events and we're just recycling it and keeping the cycle going. So we want to kind of recognize that cycle is happening and then disrupt it. And then of course, how does this concept map identify with or show us how we act in our communities about addiction? Well, sometimes if you look above residential schools there, and if we have loved ones in our communities that are using substances, we want to motivate them to change or to make a different lifestyle decision. But quite often what are our go-to motivators? And this is not just for us as Indigenous communities, this is how the modern world has treated addiction for a very long time. We'll motivate them by either fearing them, making them fearful around their substance use, or we'll shame them. And a great example of that is you watch the TV show Intervention. It's based out of fear and shaming the individual and the family. So this is taken through Indigenous context, but this can definitely be applied through a non-Indigenous context as well, because we can remove residential schools and put in children who have experienced early childhood trauma. We can remove the 60 scoop and put in children who have grown up in care and been in 20 different foster care homes and then aged out of the system. And then we can take out land theft and put in people who have a disability or people who don't have a home. The last thing I would say about this slide is going back to the motivators that we use is that under fear and shame there's isolation, because quite often too the way we have historically treated people who are using substances is we'll isolate them, thinking that that will be a motivator or a driving force for change. But if we're using fear, we're using shame, or we're using isolation, what we're really doing is contributing to the trauma, grief, loss, and stress that is contributing to the addiction.
And isolation is such a big piece, and I think it's a hard one because that's what we've been told we should do for so long. But we know from our research that the opposite of addiction is not abstinence, that the opposite of addiction is connection. And so we made this roots of connection map to shape that out and what that looks like. And as we kind of mentioned earlier, that for some communities, looking at harm reduction can be new work and it can be a new idea because we have these long-held beliefs and values around abstinence, and sometimes it can be difficult to know what to do. And if we're coming from a place of care and but maybe we're not totally sure what to do. And I think that's a big part of the conversations that we have is helping draw out all the things that communities are already doing to support the people that are using substances, and that we have been actually practicing harm reduction in some form for a really long time. So looking at the roots of community and looking at what that brings us, so family and friends, our cultures and tradition, and nationhood and territory. And what these pieces bring us is love and inclusion is so important to supporting people that are experiencing addiction, because for so long, like we said, they've been excluded from the picture. So focusing on relationship building, and like Charlene was mentioning, that peer involvement in finding ways that we can include people that are actively using substances into everything that we do, and focusing on that person-centered lens rather than just on their substance use. Giving people the opportunity to have purpose in their lives and to contribute. Looking at culture and tradition and how that brings us identity, power, and that opportunity for attachment. And nationhood and territory, giving us autonomy. And we know Charlene mentioned earlier land-based therapy. Like, we've heard a lot about land-based therapy lately because it's such an amazing means of having people get back out on the land and make those connections, because that's been what's helped us endure for so long. And the relationship building. So that, all of those pieces give us healing, joy, bonding, and peace, which contributes to that sense of connection, which gives us things like purpose, responsibility, empowerment, contribution, and creativity.
We use this a lot in our conversations when we're in community. Is a good thermometer of our approach. Because I think, quite often we always come from a place of really good intentions, but we don't always know how those intentions are going to fall with the people that we're providing services for, the people that we're caring for, the people that we love. So sometimes we say is we can use the red map, the blue map to kind of measure our approach and our programs and our services too. So it's a good thermometer check is do we want to be more in the blue or the red? And the blue definitely emphasizes coming from a place of connection.
So we have, at the end, we'll share several fact sheets that we've created at FNHA. The first one we'll speak to is on 5 key myths that we often hear about addiction. And I think that's why it's helpful to start with looking at this red map, blue map, and kind of roots of addiction and roots of connection, because it helps us kind of rethink about the way that we look at addiction and the way that the different myths that we might carry around addiction. And so a myth that we often hear is that addiction is a choice, and if you really love me, or if you really love your kids, or if you really XYZ, many reasons, then you'd stop using substances. But I think based on what we've shared and if we really think about it, we know it's much more than a choice. No one would choose to be in addiction, and it's much more complicated than just saying no. The roots of addiction lie in trauma, grief, loss, and stress.
The second myth that we like to have a conversation about in our communities, and everywhere we go actually, is this myth that we always hear, and it's really perpetuated a lot by media and a lot of conversations that are happening out there. And that myth is we need to kick out people who sell drugs out of the community to stop the problem. But if you look at the image there, it's a newer image that we've seen recently, and it says First Nations should reconsider banishment, says an Indigenous physician. And those are stories that we like to see and like to share. But quite often, if we open up our Facebook and we're scrolling down, there's always a media website, a news website that will share another Indigenous community that has risen up and banished people who are using substances, or banished people who are selling drugs. And this perpetuates this myth that it's going to solve all the problems. And really, this is a microcosm of Canada's war on drugs and America's war on drugs, the world's war on drugs. And for us as Indigenous communities, if we're making a war on drugs, what we're really doing is making a war on our own people. And health officials across the planet are coming out and saying that the war on drugs has been the biggest colossal failure to ever happen in population and public health. It has caused way more harm than it has ever done any good for anybody. So we need to be mindful about that when we're thinking about recycling those practices and those policies in our own communities, because what it really does is it causes more harm, and it won't fix the problem. And this is a little bit of fact to back that up, is that it may look like it, because if we kick out people who sell drugs, it looks like it's an immediate action to resolve a problem. But we can only emphasize that is very, very temporary. because selling drugs is a business, and with every business there's a supply and there's a demand, and if you remove the supply, we still have a demand. And so this is where we get into the root causes of addiction and the root causes of substance use, is that there's a lot more to the story than just people who are selling drugs. And it can be, and that makes it much more harmful. First, if we're kicking out people who are selling drugs, and those people are community members. Those community members are not, standalone people. Those community members are attached to families, and they are families, attached to the community, attached to a sense of connection by being in the community. So it's broadening our conversations around that.
Mm-hmm. Yeah, and if we look to what we talked about earlier, decriminalization, and how this is part of that bigger piece, is that at some point in time, these illegal drugs were once legal, and they weren't made illegal because of public health concerns. They're often made illegal because of racism. So the third myth is that harm reduction is enabling. Why would we give people new needles, or safer smoking kits, or give lunch to people who have issues with substances? We hear this not as frequently as before, but there's this idea that providing harm reduction tools, whether it's education, whether it's support, it is enabling someone to use substances. But we know that people will use substances no matter what, whether or not they're illegal, because we know the roots of addiction. And so what we need to do is provide people options so that they have agency and sovereignty over their health care, and to be able to make those decisions, and to be able to provide things like the opioid substitution therapy, or the opioid agonist therapy that you mentioned, so that people can participate and contribute in a way that works for them. And that is harm reduction, is giving people these supplies and this education, this support, so that they can give back too, and that we can work on relationships and connection, which are so important to providing support.
Another myth that we cover is all people who use substances are addicted. And we have an activity that we like to go over called the Substance Use Circle. And that really shows is that we all are connected to substance use in some type of way. And that circle really represents that we're all in this together. So within that circle, there's abstinence, where abstinence, might be many of us, might be some of us. And there's choice with abstinence. There's a whole bunch of conversations about that. Why one chooses to be abstinent. Maybe it's family history, maybe it's fear, maybe it's responsibilities, or, the conversation continues. And then there's medicinal use of substances. We use substances medicinally, and substance use for medicine, as medicine, has been great in coping with pain, people who live with daily pain in their lives. So it's a medicinal use as well. And as Indigenous people, we have lots of different substances that we use medicinally, and that's not just for us here in BC, but across the world. There are substances that we have used traditionally as a form of medicine and a form of ceremony. And then there's recreational substance use, which is substance use that is occasional, and a glass of wine after work, a beer on the weekend, or we say weekend warriors who party. Maybe it's just on the weekends, or there's concerts or music festivals or weddings, celebrations that are happening where substance use is happening. And then there's people who might have a relationship within addiction, where addiction is not a choice, as we've covered over many of the parts a couple slides ago. And addiction is not a choice. But within that, we're all in this substance use circle. And we respect where there is a choice for abstinence, or a choice for recreational use, and where there is not a choice, using substances as medicine, and within the realm of addiction, there is no choice. But we respect everybody's choices for where they are within that substance use circle. But all people who use substances are not addicted. There's those four realms within that circle.
think also kind of why we bring this up too is that there's a lot of concern around fentanyl, and kind of you alluded to this like sensationalism around fentanyl, and that people are just afraid to take it even if they might be experiencing pain, or people that have been for a long time using fentanyl patches to manage chronic pain, then they have concerns because people are telling them, well, fentanyl is you shouldn't be doing that because it's bad, it's a bad drug, right? But I think what we want to say with this slide is that lots of us have been prescribed opioids at some point in the hospital for dental surgery or different things going on, short-term stays, and we haven't necessarily come out of that experiencing addiction. So I think all this to say is that there are many different types of substance use. We often talk about addiction, but that's one piece.
People are mentioning in the chat box how hard it is to quit smoking.
Oh, yes.
As an example.
Yeah. After we've spent some safe time, safe place to decolonize our thoughts about addiction, we come to a place of what is next. And what is next is what we call the good work. And that good work is really taking care of each other, regardless of where anybody's at on their own healing journey. So we introduce the notion of harm reduction. And harm reduction, quite often, when we talk about it, is talked about two lenses mainly. Quite often when we talk about harm reduction in society, we come at it through this public health lens that harm reduction saves lives and prevents the transmission of diseases. Or sometimes we come at harm reduction conversations as a political aspect, and that harm reduction saves more money than what we would spend if harm reduction wasn't there. But what we like to do in our conversations with communities is let's talk about harm reduction through a human-based lens. And we emphasize that through our linkages and our teachings through our culture and tradition. So we highlight what harm reduction looks like, and that looks like needle distribution, providing condoms, outreach, developing relationships, providing support and education, and respecting people's dignity and human rights. And then we make those linkages between those things that are near and dear to our hearts in every single one of our communities. We call those intergenerational strengths. That's fishing and hunting, storytelling, language, gathering in our territories, artwork, canoeing, singing, dancing, ceremony, and most importantly, spending time with one another. And they carry the same amount of attitudes and actions. It takes the same attitudes and actions to carry out the work of harm reduction as it does culture and tradition. And that's coming from a place of compassion, mindful judgment, relationships, inclusion, being patient, providing care, positive communication, and meeting people where they're at instead of telling them where they should be.
So mindful judgment. We say mindful judgment because in kind of this public health harm reduction field, we often hear just be non-judgmental, like just don't judge people for what they're doing. But we know that's not possible because we judge everything we do every day. That's how we live. And so we say we should try to exercise mindful judgment, which is acknowledging that we do have judgments, but are they helpful or are they unhelpful? Are they supportive or not? And thinking about it in those terms, I think, is for us a lot more useful because we all have different levels of comfort in with this information, working in addiction, working in harm reduction, because of our personal experiences and our the different takes that we have on it. And so sometimes, we work with people who might be tasked with distributing naloxone kits, but say, I'm actually quite uncomfortable about this. I don't know how I feel about people using substances, so I don't know that I'm the right person to be doing this. And we'll say, great, find someone who is, because we need people to be authentic and come from this heart-centered place, and to use mindful judgment to acknowledge that maybe we're not the right people to be providing services, but we're going to work to find somebody that can do it. And I think that really speaks to the importance as well of that peer involvement.
out of our conversations, we've developed this learning tool to just really be a placeholder of having these important conversations. And we call it the Indigenous Harm Reduction Principles and Practice. We call them principles because they align with our cultural principles, recognizing that we're all on our own healing journey and coming from a place of healing. And to come from a place of healing is to come from a place of strength-based and honoring our intergenerational strengths at the same time, which is our culture and tradition. And our practice, we call them practice because they are in action. They are alive and well. I think it's safe for us to say that every single community that we have visited is practicing, harm reduction in some form or fashion, and has been for a very, very long time, and just not called it harm reduction. So we call them practice because it's all of our Indigenous languages are rooted in verbs and action-based words. So we call them practice because they're alive and well, and they've been happening. They're represented in the teachings that we reflect on by these 4 prominent animals here in BC, and that is the eagle, the raven, the wolf, and the bear. And we've chosen to reflect on our teachings by the animals to just remind us about the importance of getting back to our roots and honoring our cultural and traditions, and coming at sensitive and complex conversations in a good way by relying on something that is so traditional. And it's easy to grasp that idea when we look at our artwork, when we look at our stories and our myths and our legends. They all come from a place of Mother Nature, a place of our environment, and these 4 animals are prominent all across BC, and they have universal symbols that we kind of applied to them too, that directly align with the good work.
Mm-hmm. Yeah, you may remember this, if you tuned in last year, you may remember this model or this principles and practices last year, but we didn't have this artwork yet. This was created by an artist from Tsleil-Waututh. So we're happy to have this and share our new version.
So each of the animals you see here have been separated, and every animal will have symbols attached to it. And those symbols are in alignment with regular harm reduction conversations that we have. And for every animal, under the symbols, you'll see a healing principle. So when we were talking about addiction and how we would define addiction, and given the colonial events that we've endured over the last few hundred years, what we say is when we're coming from a place of harm reduction and we're looking at substance use and addiction, that we say it's a reflection of healing. And so caring for people is honoring that healing approach. So every animal will have a healing principle attached to it. Mm-hmm. So for the wolf, a symbol of relationships and care, healing requires working together as one heart and one mind. The bear, a symbol of strength and protection. Healing is embedded in culture and tradition, really honoring and holding up our intergenerational strengths. The eagle, a symbol of knowledge and wisdom. Healing requires time, patience, and reflection. One of the components for the eagle is really emphasizing self-care and community care for people who are supporting people who are using substances. The raven, identity and transformation. Healing involves finding out who you are and accepting who you were.
And the harm reduction principles and practices really serve as a placeholder, we would say, for much of what we talked about before. Is all of what we talked about can fit into this model, and it can each provide a different conversation piece. And many of the communities that we've worked with have used this model as their own and looked at the things that they're doing in their community around harm reduction and placed it within this model of looking at relationships and care and knowledge and wisdom and identity transformation.
We've had really great feedback on the principles and practice, and it is available on our website, and kind of goes into a little bit more examples of what services could look like in our communities that align with culture and tradition and harm reduction.
Mm-hmm. So the first piece of the model that we'll speak to is the wolf, and this is the symbol of relationships and care. So what this looks like is forming relationships and providing outreach to people who seek support. And we like to emphasize that the key word here is seek. So we're providing what people are asking of us, not telling people what we think they ought to be doing. And so this can be hard because sometimes when we're working on relationships, and we're, especially as family members or as healthcare providers, we're super excited that people are finally coming to us, right? They're coming to us and they're maybe asking for education or supplies, and we're so excited we have this laundry list that we want to share, like, okay, I'm going to get you your counseling appointment, your dentist appointment, and, you know, all of these things that I'm really excited about. But we have to provide what people are seeking, because we need to provide options that work for them. You know, we're not telling people what we want to do, as hard as that can be sometimes. And this sounds like connecting with people who use substances over something other than their substance use. So we kind of alluded to this earlier, or mentioned this earlier, is we're so much more than our behaviors. Substance use is one piece of that, and so it's really important that we take time to connect on the other pieces of our lives that bring us joy and bring us purpose and bring us connection. And not to mention, if I just ask Len and Sherilyn all the time, like, when are you going to treatment? You know, when are you gonna quit? Like, they're not gonna want to talk to me anymore. I'm not gonna be a safe person. And so we want to connect about the other things in our lives, not just the substance use.
The bear. This looks like recognizing that culture and tradition are intergenerational strengths and keep communities resilient. This sounds like practicing culture and tradition and maintaining connection and relationships. And this is an important conversation to have in our communities. And what we want to emphasize with this teaching is what we call low barrier cultural activities. Because as Indigenous peoples, we do have protocols and we do have ceremonies that do require a degree of abstinence. So we have this amazing story that from one of the communities that we visited, where they're partaking in ceremony that was around the sweat lodge. And there was a person who was using substances that wanted to be a part of the ceremony. And so instead of just saying, no, sorry, you are not in a place of, you know, being able to partake in the ceremony, what the elder did was make a place for them outside of the ceremony to care for the people who were on the inside, partaking in the ceremony that was in the sweat lodge. So they were keeping up with the fire, preparing the food, and making sure that nobody was disrupting the ceremony that was in progress. So it takes a degree of creativity in engaging people who are using substances, and making sure that they still have access to cultural activities, because culture being a tremendous source of our connection and tremendous source of our identity is key in just being a community. So just that creativity, instead of just saying no, it's like, oh, okay, well, they can't be in the tent with us doing the sweat lodge, but they can definitely have a place outside supporting us so that they still feel connected and a sense of belonging.
And I think this definitely also speaks to the isolation piece that you were mentioning earlier. Is for a long time we isolated people and said, you can't participate in this until you are not using substances, and so I mean that definitely contributes to that sense of isolation. It doesn't allow for connection to happen, and we've heard a lot of innovative ways that people have been practicing low barrier cultural activities across the province. And we were sharing at our educators forum a couple weeks ago, where we bring together educators, and there was someone who shared that they do smudging, an elder that does smudgings, and they said, I do a smudge for whoever asks for one because it's medicine, and if we give medicine to the people that need it, then, you know, why wouldn't we provide it no matter what? So I thought that was really inspirational. But of course it's going to look, all of our communities have different protocols, it's going to look different everywhere we go, but I think it's an important piece for us to consider and think about how we can implement and how we can practice. So the next piece of the model is the eagle, and the symbol is about knowledge and wisdom. This looks like meeting people where they're at on their healing journey and being mindful of where we are on our healing journey. This piece speaks to lived experience, and that some of us might have lived experience with addiction, and what worked for us isn't necessarily going to work for somebody else, and it's important to keep that at the back of our mind. It's not a one size fits all, and since addiction is personal and substance use is personal, we all have different ideas of what people should be doing or what we did, and just to be mindful, use that mindful judgment on when we're providing to support to the people in our lives. It sounds like providing good information and resources, so not just sharing on Facebook, like Len said, actively working to reduce stigma, and so trying to become a safe, if we're able to be that safe person to have conversations with, rather than shaming or judging someone for their substance use. How can we try to be open, and so we can provide the opportunity to share education or to share naloxone training, for example, with our friends and our family members that might be using substances. Being mindful of the way that we talk about substance use. So you've heard us throughout this presentation, we use people first language. We always say people who use substances, people experiencing addiction, rather than many other harmful, stigmatizing terms that we use or may have used in the past, like addict and user. And what this does when we used these labels, well, we're labeling someone, we're telling them what we think they are. We're putting that person in a box, and we're not allowing for that opportunity to change because we're labeling someone. So being mindful of the way we talk about substance use, for sure.
And last but not least, the Raven. This looks like providing ongoing opportunities for compassion and inclusion along the healing journey. This sounds like acknowledging that substance use is a journey, with abstinence not always being the end goal. I think quite often, and it's one of those things that is recycled in a lot of our conversations in society, but it's really about honoring the self-determination and the choices for people who are using substances. That abstinence is not always the end goal. Sometimes the goal for some people might be exercising moderation. So maybe reducing the amount of times that they are consuming a particular substance. Or maybe the goal for some people might be substitution, so replacing one substance for something that is less harmful. Or it could be none of those.
And I think that's a really tricky part of our conversation that we often have, is how do we hold up and acknowledge people that are abstaining from substance use, because people, rightfully so, are often very proud of that, and we want to acknowledge the people for their work around that. It's very difficult if you experience an addiction to be in that place. But on the other hand, how can we still support people who are actively using substances with harm reduction? So a big piece of kind of what we've already talked about is these shared teachings, and is our work with communities and our work directed by communities, and all of the many invitations that we've had to work in community. And by this, we're sorry if you're still on the wait list. Just have to give that plug. We are now booking into September and October, but we're so honored by the response and by the fact that people are so open to having these conversations. And when we have these conversations, we always say that we really humble ourselves as learners, and we're there to kind of make space and facilitate a conversation, but we learn so much, and this is our shared teachings. I tried to call it, what did I try to call it?
I can't remember.
Best practices. Oh. And it's like shared teachings.
Yeah.
This is a cultural wellness design. So I think that we talked about language use, and we had some stories. I think another key story that I heard recently was just kind of the simple things that we might not think of, as we said, as harm reduction, or we might not think it's a big deal at all, like providing vitamins to somebody who's been, drinking for several days, or checking in on someone and making sure that they are eating. Like, these are tiny pieces that we often do every day without even thinking that it's harm reduction, because it comes from a place of caring, like this is just what we do. And the pictures here are part of our shared teachings. Is we are we've done our pilot. We are now doing a workshop called Not Just Naloxone, and maybe you've heard of it, maybe some people have taken it. And basically what Not Just Naloxone is, it's a train the trainer to train people in community to facilitate these conversations and help our 5-person team do the work across the province in a culturally safe way, in a community-based way. And so we teach on naloxone, but why it's called Not Just Naloxone is because we talked earlier that it's not just naloxone, it's looking beyond the crisis, and it's talking about addiction, and it's talking about harm reduction. We also talk about the importance of trauma-informed care and incorporating culture, and so we've been piloting. Well, we piloted the Not Just Naloxone. Now we're moving across the regions to share this, and it's been really impactful. And we've had we always include peers and do peer engagement with our train the trainer, and to provide that kind of capacity building. And so these are some pictures that we chose of our participants, and teaching each other, learning how to facilitate these types of discussions around addiction and harm reduction. And I don't know if you want to talk about community to community.
Sure. One of the great things that we find that is an intergenerational strength is the practice of storytelling. I think that as human beings, we want to, tell our story and be heard. So we have this type of engagement called community to community, which is really about bringing neighboring communities together to support one another in engaging conversations about what challenges are, and brainstorm ideas around healthy harm reduction practices that can happen or on the future of wanting to implement around implementing ways of taking care of each other and supporting people who are using substances in their community. So really that's just to honor a place of storytelling. And storytelling is one of our shared teachings that we like to emphasize everywhere we go. Because sometimes people will ask us, we're like, okay, well, where's the best place to have naloxone kits? Or where's the best place to have harm reduction supplies? And we're like, well, don't ask us, ask the people who are using substances where they want to, and ask them sit down and ask them what their story is, and what makes sense for them, where do they want to have access to these services or these supplies. So storytelling is a huge, huge component of that.
Yeah, that's an important part, I think, of our jobs too, is kind of sharing the stories in the places that we go, because working in harm reduction can often feel very isolating for people, or people that are practicing harm reduction feel isolated because for some people it is such a new concept, and they might be getting pushback. And we've heard stories of people in communities where they say, I have an open door for whoever needs to come in, whoever wants to hang out, and sometimes other people aren't supportive of that, and so I think the community to community and the Not Just Naloxone is a way of making these linkages to do that shared storytelling and to support the people that are doing the work and have been doing this work for a really long time.
So on that note, we're very proud to actually launch this. I guess that would have been in December. So this is it's a series of videos that were created in partnership between First Nations Health Authority and Vancouver Coastal Health. And it actually features Indigenous leaders talking about harm reduction, talking about stigma, talking about hopes for the future. So it actually, I believe, correct me if I'm wrong, that it started out because actually the woman in the black t-shirt in this slide, that's Sarah Levine, and she's also a member of the Indigenous Wellness Team. And she was listening to Tracy Morrison, who is she was this well-known, beloved leader in harm reduction. And listening to Tracy tell a story about what harm reduction means to her. And Sarah Levine was watching her and said, "We need to put that on video. We need to put you on video." Is that right?
Yeah.
And then from there, it kind of like germinated, and then this team with Vancouver Coastal Health got together with the woman in the blanket here. This is Asia Youngman, and she's the young filmmaker that helped create and film the videos along with Damien Eaglebear. And so it's a series of 4 videos, and we are going to show one here. But part of the goal with these videos is that they're a teaching tool, especially too for non-Indigenous people like myself and Indigenous people. But it's a way to share some of the teachings from the voices of Indigenous people. Often when we do our workshops, we do get questions from people who are Indigenous, like, how can I share this model that you created? How can I share this Indigenous perspectives on harm reduction or decolonizing addiction? And in truth, it's not actually appropriate for non-Indigenous people or settlers to, talk about Indigenous ways. So, but this was one way that this wisdom and these teachings could be shared.
We're going to show you a little snippet of the series, a little component of it. And in everything that we do, we really want to emphasize taking care of each other. So if any of our friends are tuning in from Vancouver Coastal Health and knew of our friend and champion Tracy Morrison, she is featured in this film. And we have Tracy's family's expressed permission and gratitude to carry out her good work. Tracy has done amazing work over many years in Vancouver in harm reduction and Indigenous harm reduction. And so this way is a good way to carry her work forward and continue on her good work, and her family has given us this express permission to do so. So I just wanted to say that.
Harm reduction is saving lives, either by preventing the spread of bloodborne illnesses or preventing overdose deaths. My name is Kim Calder. I'm a nurse at Vancouver Native Health. I work as an LPN, and I'm also a member of the Semiahmoo First Nation in White Rock. Because I work as a nurse, everybody who comes here knows that we have all the harm reduction supplies right inside the nursing station. I've had people who have no idea who we are, but they'll see somebody they know on the street and say, "Hey, do you know, where can I get some rigs?" And they point them in this way, and they just walk in and ask us for them, and there you go.
My name is Martin Stewart. I am Micmac from Ontario, or from Nova Scotia, but I grew up in Ontario. People are going to use, they're going to use, right? It's their lifestyle. I'm not going to judge them for doing it. I'm going to help them do it properly. As well as, if I can keep them safe enough to live their lifestyle the way they want and keep them alive long enough to want to quit, right? Then that's what I'm doing. For me, harm reduction is when they're using properly. They're doing the right routine, they're taking care of their skin, they're taking care of the injection sites, they're taking care of their mouths if they're smoking, all that stuff, right? That's what true harm reduction is for me.
My name is Andrea Medeiros, and I'm from the Haida Nation of Wilmasset, and I'm the Indigenous Wellness Educator with First Nations Health Authority. When we think about harm reduction, I think what often comes to mind is urban populations, and we often see it as an urban issue. It can be hard to see how our more rural and remote First Nations communities, or even First Nations communities in general, might fit into that picture because of the trauma, the trauma and the just suffering that drugs and alcohol and substances have caused in many of our communities. That it can be difficult to host conversations about harm reduction. Why are we giving out needles and smoking supplies when these substances have caused so many issues and hurt so many people and families. So I think that is a challenging part of the conversation, and to bring light and understanding is a really important part of our jobs, because we know that harm reduction is a way to keep people safe, and not only does it save lives, it also improves the quality of life.
My name's Dee Dee Nelson, and I work as an addictions mental health counselor. For me, it's always when a person is actively using, it's keeping them safer, keeping them healthier, and providing different avenues of wellness for them and with them, because they're the ones that are often the people that are the experts on how they're doing and what they need.
Hi, my name is Patrick Smith. My traditional name is Forebears, and I come from the Kwaigaluth Nation on Vancouver Island. I'm Director of Aboriginal Health for PHS Community Services Society. My job is always to find a way to, support people from an Indigenous lens. For me, harm reduction is about, creating hope for people. Hope that, no matter what you do, you're going to feel safe, you're going to feel loved, you're going to feel supported. For me, why we created this space was just, we wanted a safe place for people to come, connect with their culture and things like that. So we created this Natsa Malalam, we call it. We are one house, because it's open to everybody, this center. I had a pretty challenging upbringing. I had, murders of family members growing up, addictions, mental health, being evicted lots of times, So I had, a challenging life as a childhood. But some of the stories I've heard down here, people, I'm amazed that they're even alive, that they can even function, never mind smile throughout the day. They're my real heroes, a lot of them, because just strength of the human spirit, to see it in action like that, it's a beautiful thing to witness.
My name is Tracy Morrison. I'm actually from First Nations Ojibwe, and I am from actually Big Grassy Reserve. I'm here in Vancouver. I live in the downtown east side, which is kind of like the poorest postal code in Canada. The community itself is just an amazing community. It's my home. This is where I'm going to stay. WARS actually represents Western Aboriginal Harm Reduction Society. We're a group of people who are current, former illicit drug users and or former current illicit alcohol users. WARS is almost like a detox or a treatment for some people. Like, it was a place for me to find community, to find family, to find friendships, to empower me to be a better person. If a person's going to use, a safer way to do it. That's part of harm reduction, but it's also helping people to empower themselves and being able to accept people for who they are and not what we should be. We're people, we're not the addiction.
We just want to thank all of the voices that you heard in that video. Tracy, our friend, Martin, and Dee Dee, Patrick. Our hands go up to each and every one of them for being movers and shakers in the world of caring for people. The videos are very close to being launched, so please stay tuned to our First Nations Health Authority website, as well as Vancouver Coastal Health.
We've got about 10 minutes left.
Sure.
Okay. Well, we already talked about we talked about this a lot, so we are going to skip this slide. These are the aforementioned 3 one-pagers that are available on our website, fnha.ca/overdose. If you have further questions for us, our email address is stbbi@fnha.ca. Yes, that is as in sexually transmitted bloodborne infection. So stbbi@fnha.ca. And if you would like further information on harm reduction supplies and resources, as well as where to get naloxone kits, you can check out towardtheheart.com.
Well, thank you all. Just to let you know, we've had over 130 people dial in, and from all over BC, as well as there was someone from Amsterdam and Arizona today. So, and what you've been sharing has really been resonating with people. Some of their comments, really liked your quote about the opposite of addiction is not abstinence, it's connection. That focus on connection and that focus on people. and bringing in that cultural approach to looking at harm reduction and all that you bring from your conversations with community. So a lot of what you said has been resonating. We will have time for maybe a couple of questions if people want to pop something into the chat box. We're getting lots of thank yous and fantastic and very informative. Great presentation.
Our friends in the audience, feel free to.
Friends and family. I really liked what you said about mindful judgment, because I've done this work for many years as well, and it's hard to get past that. You know, we are human beings and we judge, and so to think about, stop and think, is this helping me or the person that I'm in relationship with or working with? Okay, so we've got one question here. How do we share gently with our non-Indigenous counterparts in a good way without judging them as well?
I appreciate that you want to be gentle about it. Although sometimes it's okay to be direct. You don't have to be gentle with non-Indigenous people. You might just have to tell it how it is, you know. I mean, I think so. Hopefully, when we're able to, you know, maybe share the videos, that could be one way, and it could just be. I've been in difficult conversations with other people, particularly non-Indigenous people, that just don't get it, and that they, you know, often their views are actually maybe unbeknownst to them quite racist and stigmatizing. And I actually think these two have done really well. I've watched them in action deal with some of these questions, and I feel like you always come out with you approach it from like almost like a curious point of view first. Like you recognize that what they're saying is inaccurate and racist at times, but you start out by saying, now let's talk about that a bit more. Like, you know, let's explore that. And I feel like that's always been quite effective. Like, it can actually change what people think. And it's often the approach that we take anyways in our workshops as well.
Or I think what you're talking about is safety planning. Make the link.
So a question here. So it is tough as well to extend this mindful judgment to a family member whose addiction has brought much pain to loved ones. Any words of wisdom, guidance?
I think we failed to mention earlier, and especially in this time of responding to a crisis and supporting, moving us to a place where we are kind of forced into thinking about things differently, even if we're not totally ready, is the importance of self-care and making sure that it's hard, it's messy, it's difficult, it's complicated to support the people that we love in our lives that are maybe experiencing addiction or even substance use. And so I think that is a really key piece is using the boundary setting for ourselves, doing what we can, but making sure that we really take that time to take care of ourselves in whatever way that looks like.
That's another comment question. I want to mention that back in the dark era, there are a number of FAS, FAE clients we deal with that are in addictions, and it's similar to mental health and physical. Another question here about as a non-Indigenous individual who has serious admiration or respect for the Indigenous cultures and still learning so much, how can I be sensitive to Indigenous individuals and inquire appropriately about the culture and traditions, and how can I be involved in the culture? So this will be our last question.
Sure. I would just come from a place of emphasizing relationships everywhere we go, working together. And then just always being mindful about who might be missing, who's at the table, or who's not at the table that should be there. So always just emphasizing on partnerships and relationships, and then who can speak to what, because sometimes there are things, you know, on our team we like to emphasize balance, and maybe this is something that would be more appropriately coming from Medley, or more appropriately coming from Sherilyn, or more appropriately be coming from me, because, you know, we're stronger together, and I can't speak to to certain issues that maybe Andrea or Sherilyn can speak to us. So I think, just emphasizing on camaraderie and a collective. I think that's
I mean, I think it's an important question for all of us to think about. Sherilyn and I on our drive here, we were talking about the idea of, we're going to ask you after, but, to put you on the spot, but, I was talking about the idea as an Indigenous person, introducing myself as a settler on Coast Salish territory, because I'm not from here, so I think using, no matter whether or not we're Indigenous, reflecting on kind of the things that we've been doing, and are they the correct way of doing things, or the most helpful, most mindful way of doing things in the work that we do. I think that self-reflection is the biggest piece that we have. But we can talk about it later.
We can talk about it later.
Well, we're coming to the end of our time. I want to thank everyone for joining us today from near and far, and joining for this really important conversation, and to the Indigenous Wellness Team for doing such amazing, encouraging work. It's incredible to hear the conversations that you've been having, and how many conversations you've been having in community, and the response that you're getting.
We want to thank the UBC Learning Circle. We want to thank you, Melanie, and Davina, and
Javier.
Thank you so much.
Thank you.
Yeah.
Yes, so please keep an eye on our website for upcoming sessions, and thank you again, everyone, for joining us today, and to the team. Thank you.